Sorry about that. That was very loud. Apologies.
So what are we thinking about here? Rhabdo? Dr. Dave, rhabdo after fasting? Rhabdo very less likely. Sepsis, yes. Immobilization, yes. Compartment syndrome, yes. Muscle injury, yes. Dehydration, yes. Starvation, yes. But fasting is not starvation. Fasting period, like you haven't eaten for example, 8 hours. You have fasted for 8 hours. They're talking about that. Starvation, if they use the word starvation, then yes, you should be concerned about rhabdomyolysis. But fasting, no. If a patient fasts, especially in Gilbert syndrome, they become jaundiced, which is unconjugated hyperbilirubinemia. All right, so this is Gilbert syndrome. So it's bilirubin unconjugated hyperbilirubinemia because there's an enzyme in the liver that doesn't do its job. So you do a full blood count, blood film, and haptoglobin to exclude hemolysis. Fasting level can be measured. I think urodenyl glutamirase transferase genotyping is the enzyme which is not working. But essentially, you don't do anything. These patients are absolutely fine. They are just at high risk of developing gallstones. That's it. Nothing happens in them. So you just do lots of reassurance. That's it. You don't do anything else. All right. Scabies. A child with scabies is not responding to permethrin. I think this is one of the most repeated questions in exam. So what would you do? Scabies is very common here in Australia, especially in the Aboriginal population. So they will always ask you something like that. So you give ivermectin, give steroid cream, or give benzoyl peroxide. We give ivermectin. Yes, you're right. Cool, cool. Should have skipped this question. I think we have discussed this. Or maybe in the previous batch. So RACGP, going to the bottom where the treatment, age appropriate treatment. Okay. So if the child is younger than 2 months of age, you use crotamitol, and that is topical. Apply to the whole body, wash off after 24 hours, and repeat for 3 days. More than 2 months, you start with permethrin. Second line is you can give benzyl benzoate, not benzyl peroxide. Okay. Benzyl peroxide is acne treatment. Benzyl benzoate is scabies treatment. Older than 6 months of age, you can give second line benzyl benzoate. 5 years of older, third line treatment is ivermectin. Okay. Next question, guys. Now they are asking you about VTE prophylaxis for a patient after surgery of a complicated peptic ulcer disease. Sorry, should give PUD capital. What is your answer? Give rivaroxaban, give Clexane for 10 days, give warfarin, or just give compression stockings? Most appropriate. Compression stockings, yes, we do, but it's not enough to prevent VTE. We give rivaroxaban? No, we don't give rivaroxaban. Where are you giving DOAC as a prophylaxis of VTE? Especially post-surgery. Why are we giving DOAC? Warfarin? Why do you want to give warfarin and do INR testing every other day? Just give Clexane, people. Just give, just give, just give low molecular weight heparin. Just give post-surgery patient. We don't need to give big things. Just give Clexane for 10 days. That will be enough. I know it happens. Their thromboembolism prophylaxis is basically VTE prophylaxis, and it's a complicated PUD. So we know this patient is not going to be getting out of bed and is becoming a risk because post-surgery immobilization is a risk factor for VTE, right? It's after the surgery. No, it won't be bleed. So just give Clexane for 10 days. Rivaroxaban, always think about for patients in AF and in stroke. So AF, CHA2DS2-VASc score, give DOAC. Warfarin is not very commonly used now because of its repeated INR testing and dose adjustment. But if the patient have kidney failure with creatinine clearance less than 30, we do use warfarin. Or if the patient on rivaroxaban had a VTE, then meaning this is not working, so we give warfarin. Okay. I always share this VT prevention guideline. It's a very, very beautifully written. It has everything you need for your exam, basically regarding VT prophylaxis, VTE, reversals, anticoagulation reversals, everything that you need to know about. Okay, so just read this one, guys, and don't worry, don't be worried. That's okay, Dr. Neri. It happens to everyone. Don't get worried. I am just going to help you out. Nobody is judging anybody. Just relax and just try to listen because I know your brains have stopped working. Mine has stopped working, so I can't blame you guys. Okay, let's finish this quickly so you all can rest. A patient with sudden onset of severe headache associated with neck stiffness and history of bloatable kidneys, but normal blood pressure. What is the diagnosis? This is subarachnoid hemorrhage. Bloatable kidneys, what are they saying to us? Very good. Polycystic kidney disease. See, you guys know everything. You guys know everything. All right, next one. Patient presented with jaundice, no abdominal pain, and pale stools. Developed jaundice few days after taking amoxicillin and another drug. In investigation, your ALT, AST are mildly elevated. ALP is elevated. GGT is elevated. So what is the cause? Very good. In drug-induced jaundice, always remember, guys, your ALP will be highly elevated other than ALT and AST. Your ALP will be elevated, whereas in cholelithiasis, less elevated. Okay? That's the only difference. Everything else will be the same. ALT will be elevated, AST will be elevated, GGT will be elevated, but ALP much more elevated in drug-induced cholestasis. Don't know the reason, please don't ask me about that. I don't know the reason. All right, next question. Elderly patient with painful knee, temperature is elevated, has low blood pressure and is tachycardic. What is your next action? Ultrasound, X-ray, or send to emergency department? Very good. Patient is having septic arthritis with systemic features. So temperature is high, low blood pressure, tachycardia. This is indicating sepsis is happening. Send the patient to ED, please. Send the patient. They need to be started on IV antibiotics, have blood cultures, and draining and wash out of the joint. Very good. Excellent. Okay, last question. Oh, this was the last question. That will be all for today, everyone. I'm very sorry about um, the late technical difficulty that happened. Apologies. But I hope you had. Where did I put your question, Dr. Noor? I think I did put it somewhere. Uh, can you share it again if that's okay with you? Can't find it. I did put it somewhere. Maybe this one. Let me just check quickly. Where did I put it? I did put it somewhere. I'm sorry, I can't find it. Okay. A nurse who works in ward specializing in care of patients with cytomegalovirus has history of recurrent miscarriages. What is the most likely cause for her recurrent miscarriages? Cervical incompetence. She works in ward that cares for cytomegalovirus infections, has history of recurrent miscarriages. Most likely cause, so could be. Could be cytomegalovirus leads to miscarriages. It does. It does. But does it cause recurrent miscarriages? It is associated with miscarriages. Mm, I don't know why I'm thinking about maternal anticardiolipin syndrome, to be honest. Yes, I'm thinking about maternal antiphospholipid syndrome because that is the most common cause of recurrent miscarriages, not cytomegalovirus, but the nurse is working in the mm, cytomegalovirus ward. Okay. Dr. Noor, I am going to study this first because I have a feeling this is option E instead of B. Um, but let me study on that and I'll get back to you. Okay? Because I think it's E. Most common cause of recurrent miscarriage is E. Yeah, it is a E actually. Okay. Woman with 3 pregnancy losses, first at 15 week with anencephaly, other 2 pregnancies, 17, 20 didn't mention reason for pregnancy infection, so I can anencephaly. So 15 weeks anencephaly, that was a genetic defect. But then she had 2 pregnancy losses at 17 and 20 weeks. Again, I think it will be either cervical incompetence or antiphospholipid syndrome, but more likely antiphospholipid because recurrent miscarriages. Cervical incompetence miscarriages are mostly in the second trimester. So, how many weeks is that? 17 to 20 weeks. I think this one, the 17 and 20 weeks one, this is cervical incompetence, because in cervical incompetence you will have miscarriages most commonly in the second trimester. So I think this is the three pregnancy losses with first at 15 weeks and then 17, 20. This is cervical incompetence. Syphilis can cause such no presentation. Increasing gaps between miscarriages. Syphilis can cause, but the patient will have symptoms of syphilis. Mhm. Sudden onset of chest pain, then I would do ECG first. Always, if the patient is having sudden onset of chest pain associated with shortness of breath, please do ECG first. 45-year-old want to rule out MI rather than CT. Both are life threatening, but ECG will not take much time. I agree with the first question. It will be a antiphospholipid syndrome, and the second question that you shared, Dr. Nurul Haq, that will be the cervical incompetence. First trimester is a antiphospholipid, and second is the yes, Dr. Faiza. Yes. If patient plans for commit suicide, that's severe depression, admit the patient, please. But only suicide ideation, you start with cognitive behavioral therapy and antidepressants. No, no. Dr. Sandra, we need to establish Gillick competence in that patient. If the Gillick competence is not established, then no contraception other than barrier method. Not assessment of suicidal thoughts, suicidal ideation / intention / attempt is a part of cognitive behavioral therapy. Oh, yes, in cognitive behavioral therapy, we do explore that. Yes. No problem. All right, everyone. You take care of yourself. I'll see you all on 24th of this month, okay? Thank you. Good night.